Hi, everyone. Thanks so much for joining us for this webinar. We're really excited. I'm going to hand it over to Glenn Herrington, who is a member of the Early Career Committee with HFSA, and he will kick things off.
Thanks, Kelly. Like Kelly said, my name is Glenn Herrington. I'm one of the pharmacists on the Early Career Committee with HFSA. I work with Novant Health down in Wilmington, North Carolina, in our outpatient ambulatory clinic. I've been full-time in cardiology since about 2019. We're very lucky tonight to have several great cardiology pharmacists joining us to share some of their experience kind of throughout their early career and into their mid-career to give some tips and advice on where they're at. We're also really happy to have Stormi Gale joining us as a representative from the ACCP Cardiology PRN. And I'll give her a few minutes to introduce herself before we get started.
Thanks, Glenn. Hey, everybody. My name's Stormi. I am currently a cardiac ICU pharmacist at Atrium Health Carolinas Medical Center in Charlotte, North Carolina. And I just want to start by thanking everyone for coming today. Hopefully, we're going to have a really interactive session. We have some great pharmacists with us. And we have a bunch of questions that we'll go through, but if you think of anything that you really want to know the answer to, feel free to throw it in the chat or raise your hand and we'll try to get to as many questions as we can. And with that, I'm going to go ahead and work and have each of our panelists introduce themselves. So I'll start by calling on Kristen because she's the first one on my screen. And then Kristen, after you're done, if you want to just call the next person.
Great. Thanks, Stormi. Thanks, everyone, for joining today. Thanks for inviting me. Kristen Pogue. I am currently a Regional Medical Scientific Director with Merck and the Cardiovascular Metabolism team. I did my training at the University of Michigan, my PGY1, and I was the inaugural PGY2 cardiology under Mike Dorsch here that I'll kind of pass off to next since he's next on the screen. I do just have to read a disclosure about my current role, so that I am currently an employee of Merck, Sharp, and Dome, a subsidiary of Merck & Co. In Rahway, New Jersey, USA, and the opinions or perspectives expressed today do not represent the opinions or perspectives of my employer. So start off with a bang, and I'll hand it over to Mike.
Hey guys, thanks for having me. Thanks, Kristen. I'm a associate professor at the College of Pharmacy at University of Michigan. I think I represent the odd transition track that went from clinical to research. So my kind of, whereas Kristen's the maybe industry person, I am the transitioning to a tenure track type of research person. So I'm happy to answer any of those types of questions. And I'll go to Ian.
Okay, first let me just check that you all can hear me okay.
We can hear you.
I apologize. I've had some technical difficulties, but I'm Ian Hollis. I'm at the University of North Carolina in Chapel Hill, North Carolina. I'm from Ohio originally, went to Ohio State, did first year postgrad training at Michigan. Actually, my first cardiology rotation was with one Mike Dorsch back in the fall of 2005. So we're going to tell some stories today probably, but and then I ended up at UNC for my PGY2. I was a clinical pharmacist at the hospital exclusively in Chapel Hill for 16 years until last fall. And I just transitioned to being full-time faculty at the School of Pharmacy, the University of North Carolina. And so I'm still practicing at the hospital, but a much smaller percentage of my time.
Thanks, guys. I'm not sure if Lucy's been able to join yet. She had some stuff going on, but she's definitely going to pop on as soon as she can. With that being said, we'll go ahead and get into some of our questions. We do want to keep this informal, so feel free to speak up or drop some things in the chat. Hopefully we have some residents and maybe some students on the call. So our first question for the panel is thinking back to training. And when did you start looking for your first job kind of during that training process? And I'll let anybody take that one and start.
I mean, I can kind of jump in. I think a lot of people have these timelines in their head about when the job search can begin that are increasingly not really true anymore. I think, when I was coming through, most of us didn't start looking for a job until around the holidays or the first of the year. But I think things have changed. And I think, my own residents, I'm a program director for a cardiology residency. I basically tell them, you can start applying at any time, because I think, the job hunt is sort of interesting. Like, if places don't get, an established candidate, somebody that's in practice, that's willing to move, or, they may be looking at graduating residents, and it's never too early to get your name in the hat. And, you may be surprised. They may go through a search. They may go through all the established candidates who are in practice and decide none of them is a good fit. And then they go back to some of the other people who applied early on. And so I think I would almost argue it's never too early. I mean, just make people tell you no. I mean, you might be surprised.
Yeah, I think
that's a good perspective.
Ian, the other thing is for not to panic if you're during residency and you don't have a position, or there aren't positions that you're interested in early on. So to Ian's point, I stayed on at Michigan for almost 15 years in a clinical capacity inpatient cardiology. And my job didn't exist until May, I think, of my residency year. So it wasn't even available. And so I think a lot of residents get worked up that, one of their co-residents has a position and when am I going to get a position? But things are kind of continuing to evolve. And so to never panic, things continue to kind of pop up too.
Yeah, Kristen,
Mike,
I think that's a really good point. That happened to me as well, where by the end of my residency, I still did not have a position, and then something opened up and it was like my dream job. So you never know what's going to happen. I think we make a lot of decisions about various things with work, and sometimes we don't really know how big or small the decisions are when we're making them. So I'll start with you, Mike, since you didn't get a chance to speak during the first question, but are there any decisions that you made that you felt like really were pivotal moments for you in your career trajectory?
There's a lot of them. From a research perspective, looking backwards, I think I'll say for me, a master's degree, but for other people, it could be different types of training programs. That's probably if you're going down the research track, there's gone are the days of a PharmD getting you lots of research and getting a tenure track position. At least at like R1 schools like Michigan and UNC and others. So for me, the decision of getting a master's degree in clinical research was like hugely pivotal for the rest of my career.
How about you, Kristen?
I think there's two. One was actually before I did residency. I think people that know me well might know this story, but I had signed on to work retail for after graduating pharmacy school. So it's all I really knew growing up in a small town in Ontario. And I got to rotation and was like, no, this is really has to be my thing. So I made the decision to take out extra loans to pay back that so I could go and pursue residency training. So that was, I think, a really big thing. And then the second would be kind of not to like talk about Michigan and Mike too much, but to trust Mike and to be the first person in a residency program. At the time, there were obviously much less programs and it was just really starting to expand. And so as a very type A person, going into something that wasn't structured yet was a little bit kind of nerve-wracking, but putting my faith in Mike and the University of Michigan and the training programs that they already had was like just life altering. Never thought I'd be kind of where I am today. And those are kind of the two big things I can think of.
Yeah, absolutely. Hindsight's 2022, right? So it's nice that we're kind of established in our careers and we can think back and reflect on some of those pivotal decisions that I can think back to when I was first starting out, and those are scary things. So it's nice to hear from folks that, we've made it through that and you can look back and share those. that being said, we'll transition a little bit, thinking specifically about cardiology and the heart failure community, such as ACCP's Cardiology PRN or HFSA or the other organizations, and then just, being part of the overall cardiology community in general. What kind of led you on a path to being a heart failure provider, and are there any strategies or tips that you might recommend to somebody that maybe is thinking that they want to pursue a career in cardiology, specifically for heart failure? Um, Ian, you want to start us off?
Excuse me. Yeah, I guess my path to being a quote unquote heart failure pharmacist was a little winding. My first position out of residency was actually as a cardiac surgery ICU pharmacist at UNC. And so my role was to cover, cardiac patients, some thoracic, even some vascular patients. And it was just sort of somewhat by chance. I started my career in 2007, and this is right when the HeartMate 2 LVAD was really hitting the market and starting to become big. And so I just happened to be there when we started this program and started putting in a lot of these devices. I think the first year I was there, we put in like 6. Then the next year it was like 12. Then it was like 18. Then it kept going up every year. And so I sort of morphed into an advanced heart failure pharmacist just because that was super interesting to me. It was a cutting edge new thing. And our institution needed somebody to be the pharmacist for that, that new emerging therapy. And so I think if I'm going to create a takeaway point out of that, it's just, kind of pay attention to what's happening around you. And if there are new emerging therapies or new emerging types of pharmacist roles or just new opportunities, and if it's something you think you'd be interested in, if you kind of take the long view, it could really turn into a fulfilling career. It could, you could be the first the first pharmacist in a particular area doing cool things. So
Yeah, I would echo that too. Just follow where your heart takes you and what you're passionate about and good at, and opportunities will come your way, right? Mike, did you have anything that you wanted to add?
The only thing I would say about heart failure from a research perspective is that there's this term that I'll say some of my colleagues use, and I will only say it in a group of pharmacists, is that there's like this heart failure mafia. I don't know if other people have heard the term heart failure mafia, but from a research perspective, it's hard to get into the world of heart failure, and even harder to get in the world of heart failure where you can actually do impactful research. And so, we'll get to, I think, some of these other questions, but like really important things, and from a research perspective in heart failure, are finding a good mentor, finding people that can help, find places for that you can go into, and meaning places like go to this meeting, meet with this person, or here's a person to stay away from, right? Because that can be just as impactful as the people they introduce you to, is stay away from these people. And so like finding good mentors and really trying to weave your way into from a research perspective, the heart failure world, because it can be cutthroat and people can, steal ideas, be negative, especially as pharmacists in the world of research, it can be hard. So.
Yeah. And not to make this a marketing or advertising, session for HFSA, but going to the meetings and, like you said, networking and making those connections lead to those opportunities. I know in my personal experience too, not that I'm big into research, but I've had lots of things come my way just because somebody on some committee remembered me and sent something my way. That's great. There was a question in the chat that was related. I don't know if you guys had some comments. From a pharmacist. Looks like they're board certified in geriatric pharmacy, and they're wondering about some certifications. So like the HFSA's optimal medication therapy certificate, or maybe the HF-Cert certificate. Thinking about somebody that's maybe anticipating a career change, or wanting to shift out of geriatric pharmacy into heart failure. What are your thoughts on the value of those certificates? Mike, do you have any thoughts? I'm looking at your face.
Yeah, I mean, I'm so far out of clinical practice now that I mean, if I was an administrator and I was looking for someone to fill a role, having that would be good and be better than not having it, especially if you were transitioning and you could tell a good story about that transition. But I'm far away from the roles where I would make any decisions about hiring cardiology pharmacists.
Sure. Does anybody else have any thoughts about that they want to
Yeah, I mean, I think Mike makes a good point. I think it's about getting the training, but then having a sense of exactly what you want to do with it and how it's going to help you and what you learned and how you're going to apply it and those types of things. So I think if you can weave that into a message around, you know, this is why I did it, this is what I learned, here are the things I have taken from that I can, if you're interviewing, that I can readily apply at your institution and make things better. I think it definitely can have some power and give you some traction.
Yeah, I agree. Especially if somebody looking to make a career change and you're trying to set yourself apart, from other candidates or demonstrate that you do have these skills, those certificates do go a long way in that, especially early career or people who are looking to make those transitions. But, later on down the line, once you're kind of established, I'm actively trying to lose certificates, but I think there is definitely a role for those for sure. Speaking as somebody who got their HF certification last year, and the reason I was motivated to do it was part of the pathway to become a fellow of HFSA. So there's some other things to think about too if you're into that stuff.
Well, I
But
think
I'll stop.
if you tie some of these concepts together, I think doing a certificate program like that means you're probably going to be exposed to other people who are doing the same certificate program, and then that becomes a networking opportunity. You go through it together. I'm sure there's a lot of applied things about, how would you use this at your institution? You can listen to the people around you and get some ideas and build some collaborations. And so that can be really powerful too.
Yeah, I
Yeah,
completely
100%.
agree with everything that's been said about that. And I would just add that, a lot of these specialist positions or even just general cardiology positions are getting more and more competitive. And so anything that you can do, someone already mentioned setting yourself apart, but just we've all had a glimpse of how HR works. And so, a lot of these positions, when they're getting listed, you have to have something there for your application to even make it to stage B. And so I do think from even a standpoint of advancing in the recruitment process, it's helpful to have something like that sets you apart. Speaking of kind of changing career paths, I'm interested for Kristen to weigh in on sort of her decision making when she's sort of made the switch somewhat recently, right, Kristen?
Yeah, so my path before the switch to just kind of, I followed a little bit Mike. I followed Mike my whole career. I always joke that he can't get rid of me, but I was a full hospital, like full fac or full clinical person at the college or at the University of Michigan inpatient, working with kind of a variety of the inpatient services, including heart failure. And then we kind of continued to grow the team and evolve. And I transitioned into an 80/20 faculty member at the College of Pharmacy. I was teaching a lot voluntarily. And so it kind of made sense to fit that. And then through that transition, kind of continued to look for ways to continue to progress in clinical practice. And as we know, when you're in practice for that long, you have to kind of make a decision as to where you're going next. And in clinical practice, there's kind of a ceiling of you're going more into research, or into academia, or into management. I didn't want to be a people manager. I knew that about myself my kind of entire life, and maybe that will change, but I don't see it happening. And I liked research, but not enough to commit to having to secure funding and those types of things. And so trying to think about where I could go. I wanted to stay in cardiology. I wanted to still discuss science. We've obviously had a lot of folks transition into industry. And so I reached out to everyone I know who has transitioned, and even cold emailed people on LinkedIn who had recently made transitions to kind of talk about kind of what that's like and what the day-to-day is. And so being able to still be involved in some research, have scientific discussions, meet with folks within the heart failure community and learn more about what's being done in heart failure in a larger scale. I only knew the University of Michigan, and now I cover Michigan, Ohio, and Kentucky. So I get to talk to people at different centers, learn what they're doing inpatient, outpatient. And so getting to learn that those were opportunities kind of fit with being able to take a next step and continue within cardiology and within heart failure, but be able to kind of open up a world of other potential opportunities kind of down the line.
Staying on that same line of career changes, or maybe not as much of a change, but Ian, you kind of made the switch into academia, which I'm sure you were doing a ton of teaching even before making the switch, but can you talk a little bit about what sort of drove you to move into that direction?
Yeah, I think I just always enjoyed being a preceptor. During my time at the hospital, I was a very, what I call high volume preceptor, where when, you posted availability for students and residents, I basically didn't even turn the sheet in. I just said, I'll take anybody, anytime, just, and so by the time I was finishing, I had a resident nearly every month, and I had students 8 months out of the year in kind of a layered learning fashion. And so I just really got a lot of joy out of teaching cardiology to others and letting them kind of share and how fun it was and how, cool taking care of patients was. I think, like a lot of academic medical centers, our School of Pharmacy is right across the street, literally. And so there were a lot of opportunities to, run across the street and teach a class here and there. Like if you were willing to do it, kind of like Kristen said, it was pretty voluntary, but, I would try to grab those opportunities and just get to see how things worked at the School of Pharmacy and like what the expectations were over there. I think, I know there's questions in the chat about being a program director. I became program director of our cards residency in 2013, and I think that's actually, a really good way to potentially prepare for a move to academia, because when I apply for the position I'm in now, it's kind of what they call quote unquote teaching faculty. So a high percentage of my time is actually in the classroom with students. And I was expected to be a course coordinator, right? So then you're responsible for sort of mapping out the progression of, how a semester is going to go. And then actually parallels pretty nicely with what I was doing as an RPD, because you've got 12 months with somebody and you need to be sort of thoughtful about, the sequencing of the rotations and what are the longitudinal experiences and, when do these things happen if they do repeat rotations, like how are they different the second time around versus the first time? And so I think I really enjoyed that, what you might call instructional design, where it was kind of like mapping out a longitudinal experience. So I was able to speak from that experience when I applied to the school. And, I felt like I had a little bit of experience, much smaller number, 2 residents versus 150 students. But so I think being an RPD is one of the things you can do in a clinical role that'll kind of get you in that mindset, and kind of get you in that teaching. I started to dabble a lot. I know Mike wants to talk about some of this too, but like you start to become really interested in like better ways to teach your residents. You kind of do things a certain way, and then you start to get curious about new modalities or new things you could have them do, and that sort of becomes fun. If you're into that kind of thing, then you're probably well suited to move over to academia. I'll kick it over to Mike. I know he wants to talk about RPD as well.
I have so much I could talk about RPD. Like that's why I said that, Tom. I'm sorry. And like because I was RPD for 10 years at Michigan, right? So and I did 4, I think, reviews of other programs. So I knew a lot of the other programs too, because I just knew how they ran their programs. So I think it's probably better for me not to talk about it, and we can go on another subject unless people really want to hear more. And Tom, you and I can, chat at some point.
We could spin off a podcast on this.
That's
Maybe
right.
I could
That's
just
right.
riff.
Just call it the RPDs or something. Yeah.
It's got to be catchier than that, but we'll think of something.
So you guys definitely have a passion for teaching. as I think a lot of us do in this field. Thinking about that, thinking back to when you were a learner and maybe some mentors that came along the way, can you think back of a specific person or maybe tell us a little bit about the most influential mentor in your career?
I can probably start. So I've had tons of mentors, people that are older than me, people that are younger than me on the spectrum. But a PGY1 preceptor of mine still sticks in my head. Actually was in Columbus, Ohio, where I trained somewhere down there. And the preceptor, like, first time she ever reflected on me that I need to really think about some things. I was not doing so well in the rotation. And, she said to me, are you a micro or a macro manager of patients? And it really, to this day, I'll still remember her and I'll remember that session that we had I don't remember anything else about that rotation other than this one session we had where she talked to me about micro versus macro. In fact, I'm a macro person, not a micro person, and Kristen will tell you that. And that's actually why research is better for me because I'm a macro person, not a micro person. But that was huge. A thing that I can still remember to this day.
Kristen, you got one for us?
Yeah, I mean, he's on the screen next to me. So Mike has been, I had, Jamie Kalis at Wayne State kind of really solidified cardiology for me. But without Mike as a program director and then as a colleague and pushing me to do things that I was maybe uncomfortable doing, but were good for me and good for the larger picture, I wouldn't be anywhere. Like, he recommended me for an ECCP talk so long ago that I was terrified to say yes to one of my first national talks. And I said yes. And then so many good things happened because of that within like PH. So I just, I don't want to go on and on about Mike, but he's been great. And I'm micro, he's macro. And so we worked really well together when we worked together as well. So.
Kristen, that's such a good point about having, just somebody recommends you for one thing, like a supporter, a mentor, and then you do that one thing, and then all of a sudden so many opportunities open up. So for people that are interested and maybe just haven't had the chance yet to get their foot in the door for those types of things, it really just takes one. And so we've already kind of discussed networking and, at meetings and these sorts of things, but that's really the place where you build those relationships and you get noticed and recommended for those types of things, and it really does open up your doors. We know in cardiology, as in many of our areas of study, things are constantly changing. And so if you're out of practice for like 5 months, all of a sudden you have no idea what's going on anymore. So can you guys talk a little bit about, maybe we'll start with Ian, how you make sure that you're staying up to date with everything that's changing?
Yeah. That's a great question. I was actually just texting with some physician friends of mine yesterday about this because I was trying to pick their brain about how they stay up on things. Because, if I'm being fully honest, I think I struggle. I think a lot of clinicians probably struggle because it can just feel overwhelming. I think, what I've been trying to do lately, I made this mistake years ago where I sort of signed up for every journal table of contents to be emailed to me, like everything I could find. I just signed up for it. And then what happened was I was getting a table of contents in my inbox almost every day. And then I had all this angst about, like, I could see these things that I felt like I needed to read. And, I would make a plan to read something. And then the next day, the next table of contents comes in. And so it kind of was defeating, in the sense of, like, it just made me feel like I wasn't keeping up. And so I actually pared all of that back to about 3 or 4 journals that are really critical to, my practice. And I try to make a commitment to just like invest in those. And like each month when those come out, like, let me make sure I at least go through the abstracts. And usually there's like at least one article that you kind of want to read top to bottom. And so I think that's done a lot for my sanity, and not feeling so inadequate about all the things that were flying past my head because I couldn't, read them fast enough. So, I guess maybe what I'm advocating for is a little bit of a less is more, like pick a couple journals that you really like and just commit to those. And I guess too, like what I've tried to start doing now is, like I said, maybe I can only pick one article out of each journal that's published, but like just go ahead and read that whole thing and just invest in that one article and just accept the fact that like, okay, I'm gonna miss the other ones and maybe I'll hear about them on rounds, but like where I think you can go crazy is if you're like skimming everything and then you're not really reading anything and you're not really like getting smarter. You're not really getting to, the gist of these papers. So I've tried to just accept that I am going to be missing out on a lot of stuff, but just try to grab a few things as they fly by.
Yeah, I think that's a good point. I think probably a lot of us have made the mistake of signing up for too many tables of contents, and then your email inbox is just full of things that one day you'll get around to reading, but you never do. Kristen, what do you do, or what advice do you give to learners that you've had in the past about staying up to date?
Yeah, I think I've shared the same thing that Ian just talked about with my learners. Like, you want a table of contents, but you don't want all of them. And so trying to prioritize. But I think the other thing that has been kind of a more recent development is finding some good like podcast series that you can use. So different different journals, right, will have like Circ on the Run, and it'll kind of briefly summarize. And you can put it at 1.5 or 2 times speed if you want to kind of speed things up. But you can get brief summaries of things when you're driving, when you're running, any of that kind of stuff. And then you can use those to identify things to really dig into. And the learners have really found those to be useful as well. And then, Ian talked about using like rounds as learning as well, right? Because there are different people that are going to prioritize reading different articles. And so when you hear about that, kind of picking people's brains, and if that's something that sounds interesting, then again, pulling that paper, or if they're using that paper as a rationale for patient care decisions, like, gosh, is that what that paper actually says? Or I want to understand that. And so then using that as an impetus to kind of dig further in as well. And so again, the trying to get more, less is more, and using technology, although I am not even close to technologically savvy, but trying to use some newer methods of trying to do that as well.
Yeah, I echo that 100%. There's so many different ways that you can get your information these days, which is super nice. And I'm guilty. I have my in-basket or emails full of things that I don't read, but I do find that podcasts help a lot because you get short little blasts of somebody kind of summarizing things, which may catch your ear. It may be something relevant to your patient you're seeing that later that day, which would then, get you to maybe dive in a little bit more into whatever that literature is. There's definitely more options out there, which I use that all the time. Perfect. So let's switch gears a little bit. Another, reflecting back on questions. So thinking about where you're at now in your career, is there something that you wish that you had known back, when you were transitioning from a learner into your early career? Is there some piece of information that is super helpful that you'd want to share with somebody else, some perspective you'd want to share? And I'll start with you, Mike.
So again, I'm going to come to this from a research perspective. If I would have known in 2003 how important a PhD would be to career trajectories in research, I probably would have done a PhD. And so, if anyone on the call is interested in research, I'm happy to talk to them on the side about this type of thing, because we talk about it all the time, because we're constantly looking for new tenure track faculty members and things like that, where now pretty much a PharmD PhD is kind of like the standard for a pharmacy researcher or somebody that has a PhD in a realm that's related to pharmacy. And so that's probably one thing that I would say from a research perspective.
Ian?
Yeah, I'm kind of trying to decide which one I want to point out. I think this may not be exactly what you asked, but it was one of the other questions. But I think one of the things I've realized in my career is that I haven't been open-minded enough about potential opportunities. I think I make no mistake, I love my time at UNC. I am very blessed to have had the opportunities that I've had, but I think I probably like what I would recommend to younger people is to not be afraid to look around when positions are posted. Like, think about interviewing at places. There's so much you can learn from interviewing, and there's so many people you can meet, even if you're not, necessarily unhappy with what you're doing. I think it can really broaden your horizons about what different opportunities are. And you may find that you end up on a different career trajectory just because of conversations you have or people you talk to or that kind of thing. And so, um, I kind of joke, I feel like I was a little bit cursed in that I landed in a job I was just very happy with. And so I think that actually prevented me from like exploring a lot of what was out there and other things I could have done. I don't have any regrets, but I think if I were giving that advice to somebody younger, I think people view interviewing or perhaps applying for positions as this like monumental step. Like if I apply, I'm basically saying I'll take the job if they give it to me. And that isn't necessarily true, right? Like you can just go get more information, maybe have a phone interview, talk to some people. I mean, you're not committing until the very end. So I think um, just keep your eyes open and keep an open mind.
We've talked a lot about sort of career transitions and starting new roles. So, since a lot of the members of this call are earlier career, I want to talk about when you sort of start a new job and you're trying to integrate yourself into the team. So this is always something that's difficult when you're a resident. You normally have a team that's already been integrated for you with your preceptor. And so we'll start with Kristen. Can you maybe talk about how you form those relationships with your team and sort of create that culture where you have an important role as the pharmacist?
Yeah, I think again, there was an established role at the University of Michigan when I kind of came on, but we were establishing a new like separated heart failure service outside of kind of our general cardiology services. When I kind of started, that was part of the kind of funding for my role. And so Mike and I shared the service, so we rotated through, but I think we had to establish kind of how the pharmacist role might be different in that service than it was on maybe a general cardiology service where there were multiple teams, a house staff service, as compared to our heart failure service that was advanced practice providers. And so you have different people that you're interacting with on a daily basis, a different kind of higher acuity patient at baseline, and identify where the pharmacist can make the biggest impact potentially as well. And we identified early on our transplant patients, our immediate post-transplant patients had a big barrier in terms of education from a medication perspective and medication reconciliation. And worked with our specialty pharmacy to establish a process that the pharmacist ran the process. We ordered all discharge meds, we did all the education with the patients, facilitated delivery of discharge medications, and not exactly heart failure, but very kind of a unique role on that service, and continues to this day. And so I think that was kind of again, thinking outside the box from what we had been doing and trying to think about how to best serve those patients given who you're working with on a day-to-day basis, because different needs from a health staff than from an advanced practice provider, that's for sure. I hope that answered your question.
Yeah, definitely. I think that's such a good point where sometimes the way that we sort of endear ourselves to the team is by doing something that maybe is not our favorite thing to do, but it's where the gap is and where the team just really needs someone to take over that responsibility. And so once you get past that point, then you can start to do the things you really want to do, and people already are interested in your services from there. Mike, anything to add there? I know you had a very similar experience as Kristen, but if you were giving advice to one of your residents about how to establish themselves in their new role.
Yeah, I haven't really had a new job since 2005. So no. So what I always told trainees and what was successful for me initially was try to engage with the providers at a level that they want to be engaged with. So like one provider that I still know today, have his cell phone and can text anytime I want. Like we originally started engaging about research, right? Every time he was on service with me, he wanted to talk about research. So we would talk about research, and he ended up being a research mentor for me in my master's program. And so I think like engaging with providers outside of that patient interaction in the patient realm can really help kind of get you in the door so they see you as something other than the person that just walks around with them and on service.
Yeah, I agree with that. You have to have the confidence and know what you're good at and what your goals are, and how you want to provide care to patients. Speaking personally from my experience, I came into a practice where there was already a pharmacist, and I was the new pharmacist joining as the heart failure pharmacist. And the other pharmacists had kind of established a practice based around medication access, which is important. Um, but my philosophy was a little bit different, more around comprehensive management of patients. And I was asking for 1 hour visits versus 30 minutes up front. And so, you know, kind of setting some boundaries up front, saying like, this is my goal, this is the type of service I want to provide, this is what I can do, and then demonstrating that and showing what you're doing. It's a balancing act, right? So you want to advocate for what you want to do, but then you have to back that up with results. And if you can do that, then you'll be successful. But also you have to navigate the work environment too, with other colleagues and other pharmacists that maybe have different skill sets or want to practice in different ways, to trying to find that balance too. It can be challenging for sure. So we're gonna go ahead. Yeah,
Can I
please.
jump in there too? I
Yeah.
think too, for younger practitioners, you want to establish yourself, the ability to take care of, one patient at a time. And so being embedded on rounds and working with the team to do that and getting those skills is critical. But I think one of the ways to sort of become a more critical member of the team is to take a step back and start to look at like process and protocols and how things are done and where you can get involved to, maybe build some guidelines, build some order sets, build some multidisciplinary processes. And I think that's where you can start to really kind of move the needle, because, you can kind of take care of one patient at a time, but if you notice a problem or you notice something that could be better about how you're using a med or how patients move through the continuum of care, then, if you can get the team to work with you to get, multidisciplinary collaboration and agreement that like, okay, here's our care plan or here's our process, like that'll give you a lot of credibility, because if you are viewed as the person who, is making things better on that macro level, the micro is like the day-to-day patient by patient, but then you got to step back and do macro and not, like if something's broken, you don't want to keep just putting your finger in the leaky hole every day on rounds, but like take a step back and figure out, okay, we got to fix this. We got to talk about this. Maybe we have a disagreement. You and I don't. I've had a lot of conversations with attendings over the years just over coffee. Like rounds isn't always the place to fight some of these bigger battles, because everybody's like, you know, everybody's worried about how they're perceived and these types of things. But one of the most incredible things is if you get your attendings away from rounds and you get them out of that pressurized environment and just go grab some coffee with them or something and say like, hey, I noticed that you seem to like to use this med in this way. Tell me a little more about it. I see it a little differently, but I want to try to figure out how we can like make this work and make it better. And like sometimes they'll be so honest with you, or they'll just be very forthcoming or very, and you can really build bridges that way. And then, rather than just like hand fighting on rounds about how meds are used, like you can actually build a relationship around that. And I've had a lot of those in my career where it was like, it created so much goodwill that we had collaborated on some of this stuff. And they'll start to really view you as more than just the guy who, like someone said, shows up for rounds, but like you're a critical part of this team and we need you to make these things work. And so then that's when other opportunities will start to come to you, like, you know, such and such, you did a great job in this last thing. I got another thing. Like, let's talk about the next thing, and that's where the traction really starts.
Yeah, I agree 100%. I want to kind of keep on the same thread. There was a question I wanted to ask, kind of related to that. And I liked when you mentioned, you want to take care of that patient in front of you, but then, expanding that and growing that to a larger service and how can you reach more patients, right? And one of the challenges that I had early on was how do you advocate for that? And they don't really teach you as much as a learner, um, but maybe not so much from a formal research perspective, but, documenting the services you're providing, collecting data. How do you how would you tell a learner that you need to do that? What's the best strategy for that so that you can demonstrate what you're doing and the value back to your administration so that you can grow and advocate for more services? Any experience that you would want to share? Um, Ian, since you were on a roll, let's start with you and see what the others say.
Yeah, I'll have to admit, I'm not a great person to answer this question because I've not done a lot of that in my career. I think things have spun out of the things I've been involved in. So I think for me, for example, like what can happen is I mentioned how VADs were taking off at my institution. Like I never took my job thinking I would be an LVAD pharmacist, but then the institution needed one, and we had a lot of these patients, and it was interesting to me. And so then what happened for me was the way accreditation worked and some of the Joint Commission certifications required somebody to be the quote unquote VAD pharmacist, transplant pharmacist. And so I was able to kind of slide into that because it filled a need for the institution where, for the accreditations and certifications, we had to have somebody in those roles. So there may be opportunities like that. I know a lot of centers, depending on what like subspecialty like pulmonary hypertension or these types of things, they're looking to be a center of excellence. And oftentimes that requires that, they have a multidisciplinary team that includes a pharmacist. And so that could be a growth opportunity where if you say, okay, I need to step into this role, for the institution, which means we need somebody to backfill my other position that I was doing, you can kind of grow services that way. I know we've done that at my institution where we sort of had to have people in certain roles because that was what was required.
Kristen or Mike, do you have anything to add? I also want to ask Stormi that question too, even though she's not a panelist. We've worked on some projects and tried to expand some services together recently, thinking about like iron replacement and stuff like that. Anything you want to add?
I think the only thing I would say is try to match up those initiatives with things that the health system's already interested in is always helpful. And the fact that we're all in heart failure and heart failure is always a big interest of health systems for trying to reduce costs. So I think that can be helpful when you're trying to expand those services and find ways to show people that we can save them money is always going to be an easier way to get people on board than just to say, we're improving patient care, even though I know that is also important to our leadership. Um, I think we have about 10 minutes left. So I want to say to the group, if there are any questions that you didn't get answered, please throw them in the chat. So we probably have time for one or two more questions. And while you're thinking of those, we talked a little bit about getting involved in different organizations and networking. And maybe we'll start with Kristen here. How do you recommend pharmacists start out trying to just get involved with leadership or just any type of organization?
I think thinking kind of about my path along the way, I think, trying to do something above just membership. So obviously being a member is going to be important, but trying to find a way into doing something that is you're passionate about, that you're able to do something about. So the cardiology PRN from BCCP is one that has, been around a long time and something that's really easy to get involved with. Lots of kind of committees that you can get your foot in the door, meet some of those folks, and through that, you can then kind of continue to grow within that organization. And that's been a space where I, worked a lot previously. And so, yeah, I think trying to find a committee, and there's no shortage of opportunities, I would say, within the PRN for certain.
Yeah, not to put in a plug for the PRN, but I think it's one of what I have found to be one of the easier organizations to get involved with. There are a ton of committees, like you said, and we want people to join them. And not only do we want people to join them, we welcome people that are very active and doing new initiatives on those committees. So I will shamelessly say, if that is something that anyone is interested in, please feel free to reach out to Ian or I, and we will find a place for you to get on a committee and start getting more involved. Ian, I'll turn it over to you.
Yeah, I was listening. I think I want to tie a few things together here. And the point I want to make is that sometimes early in your career, it takes a little time for a lot of these things we're talking about to kind of take hold, right? So I think perseverance and just having patience, like I think it took me 5 years in practice or something like that to get my first peer-reviewed publication. Like I would do research, maybe the ideas weren't that great. I'd submit them, they'd get shot down. I'd be dejected. But I just kind of kept at it. And then you kind of hit, like we talked a little bit about inflection points, like you kind of get one in and then you're like, okay, I can do this. And then maybe you get your second one and now you're on a roll, you're getting good ideas, you know how to do it. And then it kind of takes off from there. I think being a part of like the cardiology PRN is the same thing. I went to several meetings before before I was able to really get any traction. Like I was just kind of attending, I was seeing what was going on. Sometimes I would throw my name in the hat. Sometimes they didn't pick me. I mean, maybe they already had, the committee was full, but I kept coming back. And then eventually you crack through and then you start to get a lot of opportunities. The same thing is true about these talks, like Kristen mentioned. I think when you're very young, a couple years out of residency, you're thinking like, man, I would love to do one of these talks. And I was that same way. I would see all these people who were really big and important doing these talks, and I think I could do that. I want to do that, and I would throw my name in, and then nobody would call, and then you get to a certain point, enough people have heard of you that like, okay, let's give this guy a try. And so then you do your first one, and if you do well, then it just skyrockets after that. So I think the big point is like, even for people who have been, successful, you may look at them and think, oh, this, they've been killing it their whole career. Not necessarily. Like, I think the first 5 years, it was kind of a struggle, trying to break through in a lot of these ways. But I think if you kind of stick with it and stay committed, then it will work out for you. Those opportunities will be there.
Yeah.
I'm going to follow up. I know I already spoke, but I'm going to follow up with Bill's question in the chat because it's kind of counter to what Ian talked about. I wanted to be involved, but I never wanted to get up in front of people and talk. And so to kind of the imposter syndrome point, I never put my hat in the ring because I didn't think I should have my hat in the ring. And so it kind of goes back to like finding somebody who pushes you to do those things or to take initiative to like do those scary things. And once you do them, I, to this day, get nervous standing up in front of people. It doesn't matter how many times I've given a talk, but just understanding that like, lots of people have those feelings, even the people that you see up on the stage that are giving these national talks. And you just have to learn your own personal ways to kind of manage that anxiety or stress and know that it's going to be okay. They wouldn't ask you to be here if you didn't deserve to be here. So making the most out of that opportunity. And so, yeah, I think I could talk about imposter syndrome for a long time, but I think just pushing through it and understanding that it is so very common, even amongst those kind of big people you see all the time.
Yeah, I echo that too. Being there, being involved, getting put into uncomfortable situations where maybe you are testing your knowledge, but then coming out of that on the other side and getting good feedback, people telling you like, oh, they really loved hearing from you, and telling you, giving you that reinforcement that you're like an expert in your field, really, counters that imposter syndrome for sure. So we're running out of time. We got about 3 minutes left. I think it's been a great talk. I can't believe it's been almost an hour. Does anybody have any final thoughts or comments that they want to add? And then we can check with Kelly and see if there's any housekeeping things before we sign off.
Yeah, I think, I know we're doing a webinar kind of talking about organizations and that type of thing, but I think being a part of organizations like the Cardiology PRN, like HFSA, for me, another big one was ISHLT, have really transformed my career. I think it allows you to collaborate with people who are doing your same job at other institutions, build relationships, build research collaborations, perhaps write papers. But it also gives you kind of a friend network outside of your institution. I like to think that a lot of people that I'm in these organizations with are true friends. Like we text now about stuff far beyond cardiology, and so I think that can be very invigorating in your career because when you're just at your institution, you've got hopefully at least a couple of partners around you, but just constantly having that contact point of people at other institutions and around the country, and just having people you can get ideas from or sometimes just vent to. I mean, over the years, I've had a lot of friends in cards pharmacy where we have group chats where sometimes it's just a little bit of therapy about how, you're struggling with something at your institution and how do you deal with this or how did you get around this? And so I can hardly overstate how important organizations can be for, just really giving you satisfaction in your career. And I think, you know, it's just, it's done so much for me personally beyond what I ever could have done just by, kind of going to work at my institution, just the leverage you can get, the opportunities you can get. So I think pick one, invest in it, like Kristen said, try to get some traction and try to be somebody who goes to that meeting each year or who becomes a committee member or becomes a committee chair, can be very transformational.
Well said. Kelly, is there anything else we need to mention or say before we sign off?
No, I just want to thank everyone for joining us tonight. This was such a great event. I hope that we'll see a lot of you in Atlanta at HFSA's annual scientific meeting. There's going to be a pharmacist reception. I think this will be the first year that we've ever done that. So we're hoping to have a good turnout. So thank you all so much and have a good night.